Welcome to our Persiska Tumor Board on myeloma. I'm Dan Pollier from the University of Colorado. I'm very excited to be with you today for some really interesting cases. I'd like to have our esteemed panelists introduce themselves, and just maybe starting from left to right, perhaps Dr. Nuka can begin.
Thank you for having me. I'm Ajay Nuka. I'm an associate professor at the Winship Cancer Institute. I am the director of the myeloma program, and I'm the medical director for the Winship Research Informatics Shared Resource.
Hi, I'm Peter Forsberg, also from University of Colorado, an assistant professor out here in the myeloma group with a specialty in myeloma and plasma cell disorders.
Thank you for having me. I'm David Schuster, and I am the director of the Division of Nuclear Medicine and Molecular Imaging at Emory University.
This is a 65-year-old female with relapsed refractory IgA Kappa Multiple myeloma who has undergone numerous lines of treatment and is now progressing again with symptomatic bony lytic lesions and extramedullary disease involvement. So the main question is, what's the next line of therapy? And I think in the myeloma world, that's probably a very frequent question. So this particular patient is at the moment having some minimal neuropathy and mild upper back pain with a performance status of 1. History of hypertension, hyperlipidemia, GERD, chronic hepatitis B, and depression. Social history, no contributory factors there, and as well as the family history. So in 2016, this patient was diagnosed with her IgA Kappa multiple myeloma and was treated with lenalidomide, bortezomib, and dexamethasone for 6 cycles, and then was maintained with lenalidomide. She had progressive Kappa light chain increases, and so was switched to carfilzomib and dexamethasone, but this was stopped because of the neuropathy, and she was then transitioned to daratumumab and dexamethasone, also complicated by side effects, and so didn't have a significant period of treatment on this regimen. She then was treated with exosumib, with lenalidomide and dexamethasone. Our panelists can please correct me if on my pronunciation if that's incorrect. And again, as it is a protease inhibitor, this was also stopped due to neuropathy. So that brings us to 2017, when she had a more conventional, old-fashioned chemotherapy regimen: dexamethasone, cisplatin, doxorubicin, cyclophosphamide, and etoposide, and did respond to this, but then progressed, and then had 2 cycles of bendamustine, again, an initial response and then progression. In 2018, she went back to carfilzomib and dexamethasone, and then had the anti-BCMA chimeric antigen receptor T cell therapy as part of a clinical trial, and unfortunately progressed in 3 months. Went back to carfilzomib, now pomalidomide and dexamethasone, and then had some palliative radiation to some lytic lesions. Bringing us into the more present era, she had elotuzumab, lenalidomide, and dexamethasone. Again, progression and now extramedullary disease, with disease in the breast tissue as well as an intraclavicular mass, which was confirmed to be a plasmacytoma. She had palliative radiation to the mass. Some of her labs are shown here. She had some degree of thrombocytopenia and anemia. Her IgG is 600, IgA 60, IgM 10, free Kappa light chain 40 milligrams per liter, free lambda 2 milligrams per liter, the ratio being 20 there. And we're going to look at her imaging now. So I'll take a breath for a second and just reflect on how impressive your field is with all of these potentially potent therapeutic options for patients, and it really is incredible what you've been able to develop, and what patients can benefit from and how you're able to, manage this disease over many, many years. So pretty amazing. Dr. Fuster.
Sure. So first from the narrative, we know this is only a sampling of the disease, but here we see a expansile rib lesion with a soft tissue component, as well as a left proximal humerus lesion. But as we know, there are multiple other lesions as described. There's a lot of FDG uptake. It's very intense.
Dr. Forsberg, perhaps, the real question we're being asked here is to just evaluate what next line of therapy might be. And I'm happy to go back in some of the slides, to refresh our memory of all the different therapies she's had. But what would you do next for a patient like this?
Yeah, I mean, it certainly is a complex scenario, and it's not an unusual one in late line myeloma as we try to pull apart what treatments a patient has received, which ones they've become what we call refractory to, developed progression while receiving that therapy as part of a combination usually, and sort of what are therapeutic options that are left that they may not have had exposure to or have had limited exposure and maybe not developed refractoriness to. So in trying to pull apart this case, she, it sounds like her most recent progressions have happened after, elotuzumab, lenalidomide, and dexamethasone immediate prior. Before that, I believe it was carfilzomib, pomalidomide, and dexamethasone, and that was after BCMA-directed CAR T-cell therapy, and prior to that, conventional chemotherapy with sort of a high intensity followed by a less intense. And prior to that, she sort of had some movement through different combinations due to intolerance and neuropathy, as well as seemingly light chain, sort of not being well controlled kind of out of the gate, unfortunately. So I guess in this situation, the things that's, we do have still some therapeutic options in our pocket that are different than what she's received to date. We do know that patients who had BCMA-directed therapies but had progression have been showing more and more evidence of still having some potential responsiveness to other BCMA-targeted therapies. So belantamab mafodotin, which is a BCMA-directed antibody drug conjugate, would be one consideration. Selinexor, which is a selective inhibitor of nuclear export, sort of a unique mechanism of action that's sort of been shown to have some activity in later line treatment settings, would be an option. I also, if I'm not mistaken, it seemed like there had been daratumumab treatment, but maybe not developed daratumumab refractoriness, so taken off because of some sort of intolerance. So in that setting, I think daratumumab would probably be a component of what I would think about moving towards next. How much we lose some of the potential activity of it in patients who've recently received elotuzumab. We don't totally know about sequential exposure to different monoclonal antibodies, but I think that would be probably the most potent class of medications, the CD38 targeting monoclonal antibodies, that she may not have had quite as much exposure to. Certainly tough to think that any agent would be best used as a monotherapy. So we may be thinking about combining these agents in a way that's not been as well evaluated on clinical trials. There's mostly been sort of phase 2 evidence regarding the combination of something like daratumumab with selinexor, which wouldn't be an FDA approved combination. We sometimes think about, using things in slightly off-label scenarios in these late line patients. So it gets into some sort of challenging waters in terms of recommending broadly. But I would be thinking about some of those options, sort of belantamab mafodotin, selinexor, and certainly daratumumab as sort of components of maybe a 3-agent combination for her, knowing that unfortunately, this is a scenario where disease is often behaving aggressively and control can be a little bit less stable. Certainly a clinical trial would be maybe the best case scenario. And if there was a route towards, sort of a good clinical trial, that, we always want to grab those moments. You never know when eligibility criteria will line up, when they may not. So if there is any route to clinical trial, you want to grab those moments and go in that direction. But beyond that, those approved treatment options would be the ones I'd be looking towards for her.
Great, thanks. Dr. Nuka, anything else to add to that? And then I have another specific question for you.
I cannot agree more about the rationale of choosing the treatments. But one thing I really want to highlight here is exactly what made that relapse to happen the way it is. So substandard treatments in myeloma are probably should be discouraged significantly. So what happened in her case was she was progressing on lenalidomide maintenance. So she's len refractory at the time, but she had series of lines of treatments, one after another, even though she was not actively progressing. You're letting the myeloma, you're taking off the control on a myeloma and letting a clone expand. So now that has led to what we finally saw, this non-secretory myeloma, which is presenting as an extramedullary masses, and this is the natural history of the myeloma. So now, where does it put us at? So any patient like this, I'd really like to put them on a clinical trial, but she has already proven to be non-secretory, so she will not be eligible for most clinical trials, 95, 96% of the clinical trials. So in that setting, going back to the drawing board to see what exactly she's received, where exactly are the ones that she's still sensitive to, brings up those, the daratumumab, and with a combination, again, single agent or monotherapy in a patient like this will not be able to hold for any long. So a combination treatment like dara plus seli is probably what, or a ADC with BCMA directed ADC like belantamab probably would be my choices as well.
So you're saying that when you're managing patients, you would not treat them, maybe, please correct me if I'm wrong, you would not treat them with combination regimens in the sort of remission setting. You would do more of an observation and wait for the disease to become again clinically symptomatic. Am I getting that right?
It's the opposite. So I'm looking at a 3-drug versus a 2-drug treatments. So we have several trials in the early relapse showing that the 3 drugs tend to keep these patients in much longer remissions. So all of what she got was doublets in the initial phases, but early relapse. And even those doublets, they were given for a brief period, and they were stopped off for minimal side effects.
So, with respect to side effects, I mean, as a myeloid malignancy person, the only thing we even have that can come close to what you have is an example of like CML, where we have a lot of different TKIs to choose from, all of which have different side effects. And, we manage them often with dose reduction. Are dose reductions, particularly like the proteasome inhibitors, are those effective ways to manage things like neuropathy or other side effects, or is it not really dose responsive?
So dose modifications really help. So in this patient's case, all we kept hearing is that mild neuropathy. So mild neuropathy is grade 1 neuropathy. If the neuropathy has any pain, it automatically upgrades to a grade 2 and beyond. Mm-hmm. So we typically make any dose reductions when there is any pain or grade 2 or above neuropathy, and that is where a dose reduction essentially helps. One thing I want to highlight is as a 3rd line of treatment or the 4th line of treatment, ixazomib, lenalidomide, dexamethasone was used, and ixazomib was stopped off due to peripheral neuropathy. If you look at the clinical trials that were evaluating ixazomib, you don't see them to have the neuropathy. So in reality, that is not the case. Ixazomib is a boronic acid inhibitor, and it does cause neuropathy, but the patient selection among those patients who did not have neuropathy were the only ones that entered the trials.
Got it. And then just one last question. This patient, if I remember correctly, did not have a stem cell transplant. And is there any, and I'm sure there were good reasons for that, but if whatever reason prevented that from happening sort of in her first remission were to be different now, is that at all a goal now that could be helpful if try to get to a transplant in this sort of multi-relapse setting?
I think it's a two ways of looking at this. It is almost impossible to collect stem cells in a patient like this. And we don't have as much data supporting an allogeneic transplant among patients where we do not have a disease control. And this is not the perfect candidate for an allo transplant.
I understand. Okay. So in this case, it sounds like the recommendations for next line of therapy would definitely be a multi-agent regimen, focusing on some of the therapies she hasn't had, like the selinexor or the BCMA-directed therapy would be considerations, and then also perhaps going back and seeing if some of the more potent therapies that she did have and had some side effects too could be sort of reassessed and maybe dose reduced, and those would be maybe the carfilzomib or daratumumab. So this is another relapsed refractory case. It's a 70-year-old female with IgA Kappa multiple myeloma who has a double hit cytogenetic profile, relapsed and/or refractory to previous treatments, most recently in a durable remission after a BCMA CAR, now 9 months later with early progression. ECOG is 1. And she has also had a multitude of prior therapies: lenalidomide, bortezomib, dexamethasone, carfilzomib, lenalidomide, dexamethasone, daratumumab, pomalidomide, and dexamethasone, and even venetoclax and bortezomib. So Dr. Forsberg, it seems like you still have, even with my naivete and the myeloma landscape, several unused options here. What would be your next step strategy?
Yeah, I think it's interesting. These are back-to-back cases of, sort of post-CAR T relapse. Both of these patients are folks who, had, sort of extensive exposure to most of our primary categories of medicines. We don't have exactly what the treatment exposure and natural history of this patient's myeloma was, but, presumably refractoriness to a lot of these agents that she's had exposure to in the past. So this may be somebody who would fulfill a category that we would call something like penta-refractory, which would be, essentially refractory to bortezomib, carfilzomib, 2 primary proteasome inhibitors, lenalidomide, pomalidomide are 2 primary immunomodulatory agents, daratumumab, and now maybe this emerging category of folks who are penta-refractory as well as relapse post BCMA-directed CAR T. So it's certainly, I think it's an area that we're going to be dealing with more and more of over time in the future. But it does, as we mentioned, it sort of overlaps into some of the therapeutic categories we just mentioned. I think that, options for this patient would include selinexor, belantamab, mufadotin. How much you want to follow one BCMA-directed therapy with another one in the exact next line of therapy, I think is an open question. If you may want to try to put a line or two of treatment between BCMA-directed approaches. Beyond that, it doesn't look like this patient has ever had much in terms of the realm of classical chemotherapies, cytotoxic agents. So I think thinking about incorporating something from that sphere might be worthwhile. We talked on the last patient about, they would have gotten, the lymphodepleting chemotherapy as part of their CAR T conditioning. So they probably have had some chemotherapy exposure, but that's the extent of it. So that could be a category that you think about incorporating. Bendamustine in combination with something like carfilzomib would be one route to that. Or if this patient did have, stem cells collected at a prior line but not used, as Dr. Nuka mentioned, it may be very challenging to collect at this point in time, but may not be impossible. So you could think about sort of approaching and seeing if there's any route towards collecting CAR Ts and collecting stem cells, because in somebody who hasn't had any chemotherapy exposure in the past, high dose melphalan may have a slightly more robust role. But I do think you'd be thinking about sort of similar groups of medicine, a selinexor based approach or something that incorporates classical chemotherapy would probably be the 2 directions I might lean.
Dr. Nuka, what would be your approach to this?
So this is a great case. Unfortunately, this is a common scenario now among those patients who are progressing on the anti-BCMA CAR-Ts. So since this patient has an ECOG performance status of a 1, so if the labs are allowing for us to get onto a clinical trial, that would be my primary approach to this patient. So in the absence of any clinical trials or in the absence of any contraindications to get, in the presence of any contraindications to getting onto a clinical trial, probably going on to what Dr. Forsberg discussed with selinexor combinations or anti-BCMA ADCs would be my choice as well.
And any enthusiasm in the clinical trial world for any specific approach, or maybe another CAR-T approach? Anything that you would just sort of I know it sounds like any clinical trial would be fine, but is there anything going on right now that the field is sort of particularly excited for, particularly after a relapse after a CAR-T, a BCMA CAR-T? So
the first question that comes to mind is, could we repeat another CAR-T in this specific patient? Would we get any further mileage? The data is very sparse, and what we had seen so far has not worked. So number two, in such scenario, is there any other way to invigorate those CAR-Ts? So we have some internal data, and I do have a investigator-initiated trial that is about to start using checkpoint blockade in these patients. And in myeloma, we do have a bad history with the checkpoint blockades in combination with the immunomodulatory agents. So it is not usually the preferred treatment because of the increased risk of mortality with these agents in combination with the IMiDs. But this is a scenario where you potentially can use an immune mechanism to reinvigorate, and that's probably an approach that I would take.
Great, interesting. So it sounds like from our panel, the recommendation would be certainly a clinical trial for this challenging scenario, and conventional treatment options would include the ADC, BCMA therapy, selinexor, and I think those are the two that mainly came up as potential next lines of therapy. Oh, and more conventional chemotherapy type of an approach.